and see what others have found also to be beneficial in their own centers. So thank you again. And this is just my disclosure. So I come from Riyadh, and Riyadh is basically the capital of Saudi Arabia. And Saudi Arabia is rapidly evolving over the last few years to accommodate major projects, as you can see here from the picture, under the Vision 2030. And we're also lucky to have Riyadh Expo 2030. We're hosting it in the year 2030. So everyone is welcome to come to see all of these mega projects. And we're also, I come from King Saud University. We have two hospitals, major hospitals, King Khalid and King Abdulaziz University hospitals, both ENT as well as general hospitals, that we do scalp-based surgery on both sides. And we developed this program over the last 10 years or so, and we'll just share some of our thoughts about that. So we'll basically go over what is a multidisciplinary team and stages of that team as well, and what are the requirements, basic requirements of that team, and then how can you actually just improve it on the long term continuously and make sure that things are getting better and better over time. So starting by and this is just from the NHS, what's a multidisciplinary team? Basically a group of professionals from one or more clinical disciplines who basically go together to make decisions regarding individual patients. So this is patient-centered care. So the patient is in the center and everyone around him trying to figure out what's best for the patient. And I think it definitely leads to better outcomes, and we'll go over that in just a second. So we as rhinologists, we come from doing sinus surgery, doing a lot of complicated polyps and a lot of complicated things within the sinonasal cavity. And the neurosurgeons come from also the other discipline where they actually operate with an open approach, doing the skull base, trying to decompress nerves, trying to remove tumors. And we basically try to combine these two elements, two experiences and two disciplines in managing some of the very complicated cases that you can see here, for example, in a child who had a very aggressive tumor involving the whole skull base and emanating from the nose all the way up to the brain itself. So you can't really do this unless you actually have a full team to accommodate and remove such a tumor. So this was paved, or the way it was paved by multiple teams, and Dr. Crow, Dr. Joe, probably one of the first teams that documented their experience in '96, just documenting on two cases of pituitary adenoma and how they dealt with it endoscopically to remove these tumors. And ever since, everything just blew up, and all the coronal and sagittal plane approaches have been fully developed and basically just rapidly evolving over the last 10 years or so. So why do we actually need this team? And this has been seen not only in ENT, not only in anterior skull base, even lateral skull base, and multiple tumors as well, and multiple areas in oncology. And this is just an example from the lateral skull base tumor side, where you basically see that these tumors, or these patients, have had decisions made without a multidisciplinary team approach, and then they've had a decision after multidisciplinary team approach, and that these approaches have changed in approximately 13 to 14% of them. So it is not a huge number, but still it is significant to lead to better outcomes. And you can actually see that within this study by Dr. Harvey's group, and they basically just compared the pre-multidisciplinary team pituitary adenoma cases with the post-multidisciplinary team approach in 5 years, and they basically just compared the outcomes between the two. And what they found, which was significant, you can actually see here that the length of hospital stay is significantly less within the post-multidisciplinary team approach. The complication rates were much less with transient DI and SAIDH. And you can see that as well, that the residual rates were much less within that group, peripheral complications, hypothyroidism. So all of that were actually less in actually having 2 or 3 or more people involved in the care of the patient. And when they study the factors, all the factors that led to better outcomes, the multidisciplinary team approach was actually the best or the most prominent factor that led to better outcomes. So this is fairly clear, and we've, multiple centers have developed this over years to have many brains basically think to see what's the best for our patients. And in terms of benefits of team surgery, and this is just an example, us doing a plenum meningioma, me and Dr. Abdulrazak Ajlan, who's the partner neurosurgeon, you can actually see that I'm holding the tumor with a giraffe forceps, and he is actually dissecting at the same time. So this is a four-hand approach. The suction is actually below the field itself. So four hands doing this in a dynamic way, trying to deal with this, and this is just the olfactory bulb on one side, trying to dissect the tumor itself. So you can see how we're seeing everything with a 30-degree endoscope, having angled instrumentation, and having a very clear view with two brains. So a second opinion is always there as well. I usually provide that to him and him to me as well. The efficiency increases dramatically in this by having two brains thinking at the same time, even more sometimes with having fellows. And the modulation of enthusiasm, where we actually try to basically either encourage or discourage from doing something, especially around the carotid and around other areas. We basically just take our opinions every now and then. And all of that basically leads to a comprehensive patient care along with the other teams that are involved. And we'll talk about that in just a second. So from a psychology point of view, what are the stages of multidisciplinary team development? And I went into the psychology of it, and Bruce Tuckman, who's a psychiatrist, basically described these stages and phases of team development, and they made sense to me as well. The first stage would be the forming stage, where you basically just see each other form, socialize, fairly polite to each other, and you basically stick to the most simple approaches, simple things, and try to figure out what works best. And then the second stage would be the storming stage, where you basically have some resistance, have some conflicts, but you definitely might have some competition as well. And then later on, this cohesion develops in the norming phase, and then improvement of the performance as well during that phase. Once the performance stage happens, is that the stable and the plateau phase at that point. And hopefully we will not adjourn at any point. So this is the forming stage for us. We're actually, it was a weird coincidence where I met Dr. Ajlan, who is my partner neurosurgeon, and the Dr. Hamid Isa, who's a head and neck oncologist as well, who I knew from before. During one of the skull-based cases, which is a CSF leak after submucous diathermy, which is a very common thing, with a very unusual complication. And although we don't really need to be involved in, or the neurosurgeons don't need to be involved in this case, you can definitely do it as a rhinologist. However, from that point and onwards, we decided to do everything as a team and always be there for each other. So the personal aspects of socializing with each other, having an open door policy on everything, and flexible boundaries are very important to try to not create those boundaries and then possibly lead to less or poor outcomes later on. Shared responsibility of everything. So we don't point fingers at anyone and saying that's your responsibility or it's everyone's responsibility at the same time, and trying to create some at least some accountability in some areas. And the clinical aspects as well that we worked on during that period of time in the beginning was just a mini board between us, just between us three. And sometimes we get the neuroradiologist on board. The equipment was a very important aspect that we had to focus on and make sure that everything is available. Disposables as well that we have to be ordered, and you have to take the leadership of the hospital or the institution in terms of convincing them of getting this in for your cases, and staff training as well. Most of the staff at that point didn't really know how to deal with these cases. Some of them had ENT experience, some of them had neurosurgery experience, but none of them had this combination experience at all. And we had to train them as we went in the first few cases. And then the second case came a bigger case of an optic pathway glioma, and this was in 2014. And you can see how it is fairly complicated, much more complicated than the first one. It was a 6-year-old who had a very aggressive tumor and very high flow CSF leak. And this basically just showcased how we can work together to have better outcomes. And that actually led to even more thinking of, is this the best for the patient? So we collaborated with an international group, and we tried to figure out what's the best outcomes. We found that the outcomes in the endoscopic approach, with the few cases that we had and the others as well, were actually equivalent, even better to the open approaches that were described in the past. And this basically led to more and more collaborative work on international as well as national level, and basically led to more things. And we thought about multiple things during that period. And we had a conflict as well during that period saying, Dr. Ajlan had a concept of, we have to clean the face, sterilize the face. And I didn't really, from my training. So we had basically a randomized 3-arm controlled trial just to figure out whether or not this actually makes any sense. And this actually went over a few years with multiple centers. So we established that national leadership as well in leading this randomized controlled trial, which has been published just recently. And we didn't really find a big difference between them. Just an FYI, you can read about that as well. We had complications, and this is, you have to have complications during skull-base surgery, but we always documented them. The shared responsibility is always there. And we basically this led to quality improvement, root cause analysis, and seeing what happened. We reported them. We tried to figure out what's the best for these patients. And then we got better in doing it. Time constraints are always there, especially in that storming phase. You have your busy rhinology practice, and he has his neurosurgery practice as well. And this is somewhere in the middle. So it's also fairly complicated, and you have to have a lot of people involved to help. Other parts of the group as well, from a rhinology aspect, came on board, and they had another experience saying, if a patient has CRS, we should probably just treat the CRS, try to figure it out before going into elective skull-base surgery, not to have worse outcomes. So I basically tried, and I didn't. I basically just did the skull-base surgery without even treating any CRS, unless they have an acute problem or acute exacerbation, which they didn't in this group at least. So we compared our results between the CRS and non-CRS group. We didn't really find a difference. So our conclusion was it wasn't really a contraindication of elective endoscopic skull-base surgery, even in the expanded approaches. So this conflict, some of the ideas that we had and some of the experiences that we had from multiple centers, we've tried to figure out what's best for our patients and on a national, regional level. And then the norming and performing stage, and this is where we try to achieve clinical excellence. We established the multidisciplinary team at that point, and the board. Weekly ORs, 1 to 2. Data collection started on a regular basis, and registry from both the data as well as biobank. Marketing on multiple levels to try to get more patients as well in national, international conferences. Referral pathways were all established on a national level. And we also went to news outlets to just let know the other national centers of what we're doing. Academic excellence was within that as well. We established a fellowship on both sides, on the neurosurgery side as well as the rhinology side, to have more experience in skull-base practice. And publications basically just were developed during the way. Courses were done on a yearly level and on an annual basis, and we'll talk about that in just a second as well. So some of the requirements that are there, and this is basically, we didn't really think about this, but when I looked into it and researched it, this is a very nice checklist on whether or not you really have a good multidisciplinary team. And it's basically 47 items that you can basically go through one by one and score yourself from a 0 to 5 point on the scale itself and seeing whether or not you're actually scoring pretty well in certain environments, certain things, going from the team itself, for the meetings, for the administration of the meetings itself, the patient clinical decision making, and what are we discussing, and the team governance, how the team actually is coherent with each other, the data as well, and the clinical governance within that team. So all of that can be critiqued on a personal level within your team as well. And we have a horizontal responsibility of all the team, and we always communicate with each other. You can see all of these teams are involved right now within the skull-based multidisciplinary program, and the coordinator in between 1 to 2 coordinators usually try to coordinate between all of these teams as much as possible. So the operative room itself, we always discuss everything. We always see the patients prior to the surgery itself in each of our clinics and discuss the approach right before the surgery with our colleagues, with our fellows as well, try to figure out the approach, figure out the reconstruction, division of labor between us, what are the potential pitfalls that we might actually get into, and check all the equipment. And this is something that we always talk to the fellows about, check the navigation system, the neurophysiology monitoring if needed, the endoscopy instruments, the hemostasis, if we need any blood as well. In the majority of these cases, we do, and the Doppler probe, whether or not we have it and whether or not we need it. And the reconstructive materials that we sometimes use, not from the patient itself. Always in the OR itself, we have a 3 to 4-handed technique. We start as a rhinologist and then with both of us, and then back to the rhinologist for the reconstruction. We won't get into the details of that. And then in terms of the levels of skull-based training, this was established by the Pittsburgh group. And you can see basically how you can go through the levels of training from simple sinus surgery all the way to very complicated vascular tumors within the skull base itself. And the majority of times, once you are involved in a skull-based fellowship, you're usually between the 3 and 4 levels, and you basically progress on if you need it. And we're now currently at the 5 level in our group. Some of the challenges that are always there, and something that I've found fairly clear to me, is that if there is an age of power disparity between the group, then there is a possibility of challenges that might arise. And you have to try to at least go to or establish relationships with someone who is of similar age, of similar experience as well. Try to have flexible schedules, especially in the beginning, and then later on it will basically just drop into their positions. Anything that leads to disruptive behavior or attitude is unacceptable by any chance. And we always have this humility that we don't know everything. We have to actually learn. We always go back to the anatomy lab with our fellows, with ourselves as well, and make sure that we're up to date with anything that we need to. And inadequate instrumentation is fairly important. You can't really do these without inadequate instrumentation and funding. So you have to make sure you have to have leadership with you to at least facilitate this happening. And you have to have a very sufficient volume of cases, or you never will get any improvement in these cases. And by establishing these referral pathways, it made it much easier for us as well. And you always have to have a mentor involved in all of these cases, especially in the beginning. We always had them on WhatsApp. We always talk to them all the time. The mentors on national level, international level, in each and every aspect of our surgeries. So we continued on even training as teams, and this is just a picture of the neurosurgeons as well as the lateral skull-based surgeons going to Germany to train for ABIs, so the 3 brainstem implants, which are fairly innovative, and not a lot of centers are actually doing them. So we still learn as a team, and this is something that is a potential or a very important requirement. So how can you actually have long-term improvement? And this is very important. And I think, I try to think about it in these areas: research, training, courses, and obtaining accreditation later on. So research is a basic infrastructure for any advanced academic scientific program like this. And by establishing the infrastructure for the database, by having a fellowship, and by having grants and a wet lab, this all are requirements to actually have potential of impactful research. This is one of our publications on the coronal aspect and anatomical study on cadavers that we got grants from on a national level. And usually we try to obtain impactful research from a clinical aspect. So this is another publication on supracellular meningioma classification. And we've had this classification on board just to see what's the effect on olfactory outcomes. And this is something that's fairly important. We always discuss whether or not you go from the above or go from below, what's best for the patient. This is still ongoing, and we'll hopefully have the publications out soon. And we basically go for Q1, Q2 journals with a goal of around 15 publications per year currently. We're hoping to go to 20 or so. This is another thing that we always have research that improves us as well. And we've had in the beginning a lot of experience using a gasket seal technique with rigid implant. This is a Med4 implant, as you can see here. And this was from Dr. Ajlan's experience. And this is what we did in the beginning. From my experience, I didn't do that. We usually had only totoplast or basically fascia in a multi-layer approach as well as a nasoseptal flap. So we stopped doing that in the we stopped doing Med4 plates in the second half of the almost 8 years or so. And we try to see whether or not that improves. Although there is also the usual progression into improvement, but we found that using Med4 plate and using a SKC technique, at least in our hands, was actually worse than not using it. So this is something just to improve ourselves. It doesn't have to be something that works in everyone's hands, but at least how can we improve as a group? And later on, innovative techniques as well were trialed. And this is just Dr. Abdulaziz Rashid, who's the current head of department. He's trying to create an L-shaped approach towards one of the meningiomas, a large one. This was done in the wet lab and then applied during the surgery. And hopefully you'll see the publication soon. Some of the techniques on how to improve and enlarge nasoseptal flaps. We adopted some technology to try to see inside with a ultrasound probe how much of the tumor is still left instead of using an MRI suite. We also use the MRI suite as well on occasion just to monitor how much of the tumor is still left. Postgraduate training is one of the hallmarks of continuous improvement. They challenge us and we challenge them all the time. And we're fairly proud of the production that we have of our colleagues now in multiple areas and multiple centers on the national and the Gulf as well levels. And we established both fellowships within the last 10 years or so. And this just led to more people even involved on a national level and developing their own skull-based teams in multiple areas around the kingdom itself. And we're definitely proud of what has happened in that, and then development of further databases and research later on. We have annual courses, and this helps in keeping our skills at best as possible. This is our next one in just a few weeks in the 5th Advanced Endoscopic Skull-Based Workshop. We also have the Rhinology workshops. And we also have a hybrid workshop that we basically have endoscopic approaches as well as open approaches, head-to-head, approaching a single area. So you can see people approaching it with a microscope and me approaching the clivus at the same time. So trying to compare and contrast between either sides, having neurosurgeons and ENT learn from each other. And this is something that we really enjoy. This is Dr. Abdulaziz, who's my partner, and the whole team as well. I'm definitely just a spokesperson of a whole big, huge team and not really just the guy. Next, what's obtaining accreditation is just to try to figure out whether our standards, whether our policies, regulations, and everything that we've done over the last 10 years or so, at that point it was less, was it actually up to par with international standards? And we approached the North American Skull-Base Society, and they've actually granted us a team of distinction. And we're actually the only team currently outside the US that obtained that distinction at this point. Well, hopefully that will have even more within the region itself. And we're really proud of that with the whole team. And it's just a small example just before we stop of a complicated esthesio, Kaddish type D, Hyams, I think 2 to 3 or so, a fairly complicated one. And one of the actual staff that actually was within the hospital itself. So we definitely start usually as a rhinologist trying to remove the tumor. This is Dr. Abdulaziz Rashid. He's the leader in this case. Performing the maxillectomy, removal of the septum, removal of the tumor within the nasal cavity itself. Then cleaning everything from the orbit on one side. So now he's doing a two-handed approach himself with the fellow, and then creating a draft 3. So you can see the ethmoid arteries. And then in usual transcranial approaches, removal of the whole skull base and resection of the tumor. You can see, just want to show and highlight this here, that Dr. Ajlan, who's a neurosurgeon, has even trained now with using rhinology instruments. So that's a sickle knife that he's using currently. As a neurosurgeon, this is a through cut, a Kuhn Rhinoforce through cutting forceps that he is actually using as a neurosurgeon. So both of us learn from each other using our instruments as well. So it's very critical for us to learn from each other all the time. And reconstruction with a pericranial flap. That we went through with the money box approach to cover the whole defect. And then later on had radiotherapy, and has been doing very well ever since. Just of note as well, the head and neck surgeons were also involved because he had a level 2 lymph node, which was also, neck dissection was also performed at the same time. And postoperative chemo radiation therapy was done. So all the teams were involved in this case to have the best approach, and he's still alive, doing well, no issues. This is now almost 4 years or so. So just to end with a quote from Henry Ford: coming together is the beginning, keeping together is progress, working together, truly working together is success, to have the better outcomes for our patients. Welcome everyone to EAACI Global Forum in Dubai in 2025 in January, and we'll discuss a lot of skull base, a lot of other things as well. One of the largest forums and meetings in the Middle East. Thank you, everyone.
Thank you, Saad, for the presentation. There's plenty questions from the audience. As I was saying, this is quite fascinating topic, especially not only for the juniors. So this is something that is more advanced, and it's somehow a mentorship and a very advanced type of behavior when it comes to establishing such a program, because it's not only on a business side, which is important, of course, and there's two questions regarding this. There's also something that you expressed before. It was not only advancing, but also making audit regarding everything you're doing to making, a safe point in which you can move forward. So let's go directly throughout the question. The question is coming from Germany. How can the program secure necessary funding for expensive technologies, training, infrastructures to support the multidisciplinary skull-base surgery program?
Yeah, well, definitely, I think this is very dependent on the center itself and the country and everything. So for us, we were lucky at that point. In the beginning, we've had multiple funds that were unused for other things, and we basically made a big proposal to try to use them to the leadership of the institution at that point, which basically was 1 + 1 = 2, and they basically used it. So we were lucky to have that. This is happening to our fellows as well when they graduate and go to their centers. They have to make that case to the leadership, to the institution, that we need definitely some of these equipment, some of the instruments. And the majority of times, you don't need very complicated ones. I would say a navigation system and possibly some instruments, basic sets of skull-base sets, as well as endoscopy towers, are probably the most basic things that you need. The other things are not that expensive, like a Doppler and other things are not that expensive in the majority of times. So if you have most of that, then the majority of times it's just the physicians themselves just sacrificing their time for this.
Yeah, that's true. That's true. Other question. This is coming from. I shouldn't say this, but I have to because I know who is. But it's a kind of a good things to tell. This is from the MD Anderson. What ethical dilemmas might arise when coordinating care among multiple specialties, particularly when there are disagreements about the best treatment options?
Well, that's where the board usually is very helpful when you have that team rounds done. And in the beginning, we've had it in person. And later on, once COVID hit, we switched to online. And ever since, we've been doing it online. And it definitely helps learning from each other. And we always have conflicts. And you can actually see the data that we've found. I've also reviewed some of the data from other disciplines. And having the conflicts leads to better outcomes. And that's the main thing. As long as everyone is actually on the same page, what benefits the patients themselves, having the evidence to support it. And this is something that's important from our side, is that we try as much as possible to provide the evidence from an internal point of view as well, not from an international point of view, not also what we have on a national level and what we've developed over years. For example, we say, we've had 100 and something cases of that. And in those cases, we've had this, and all of that is currently established and we have access to, and we can definitely just review all of that. We're also going into the second step of prediction models now. I didn't mention that as well, where we try to integrate AI to develop some decision-making, and that actually helps as well. So based on the databases, based on what we have as well, we've tried to integrate some prediction models. And I think one of my colleagues is presenting that within the next North American Skull-Base Society.
Great. Other question from Spain. What essential components that should be included when developing a multidisciplinary skull-base surgery program?
What essential components?
Yes.
So
I think that this is related not only on a team, but the fundamentals, I guess.
So I can probably summarize it in sacrificing time and effort. That's in a nutshell. If you actually have everyone involved sacrificing their time and efforts in the development of something in the greater good, that's probably the key to success. And that's what we found, at least. And you have to have at least a few people doing it. You won't find everyone doing it, and that's typical of everyone, and that's typical of everything in the world and life. But at least if you have a few people believing in the greater good, I think that's probably the heart of the essential requirements for that. Later on, everything else just develops around it magically. We see this all the time. Everything just wraps around and tries to cover all the deficiencies that we have.
A question from Greece. Have you ever faced difficulties with your neurosurgeon partner?
So as the years go by, you definitely have a very good relationship, and I hope that my neurosurgeon colleague is actually seeing this. But we joke around a lot, we socialize a lot, and definitely have a very good relationship between us. Once you see this guy for so many hours and so many days of the week, you have to have a good relationship. It becomes one part of the family, and you have to pick and choose people, and that's something important. This is what I talked about as well. You can't really go to as a starting rhinologist to a very senior neurosurgeon, for example, who did not perform any endoscopic work in the past, and all of a sudden you want to start something. It's fairly difficult to do that. So you have to pick and choose people that definitely go to the people that you might expect that would actually work with you. And if there isn't someone, then just wait for someone to come or try to get someone as part-time.
Yeah, I think that what you lately said it's important, which is do not ever choose someone that is not trained as yours when it comes to establishing such program. I remember Amin Kassan in 2013 talking about how much explore has been made initially back in 2002, 2006, but then the morbidity dropped in which you cannot do, how to say, experiment anymore. Before was something that you should have to reach to that. Now is to avoid morbidity. We cannot, express anymore muscle damage and nerve damage when we do know anatomy. And when you have the same training as per the other from the team, then you can reach to another level. This is a question from my side. Do you think that before starting any skull-based team, having guests from around the world will help you somehow to keep updated? And also, do you think that dissection courses are still beneficial?
Both are essential. I think I probably did not mention what you mentioned, but I think it's a very important aspect. So I mentioned it briefly by having international mentors. And I know that there are specific people who are pioneers and experts in dealing with certain aspects of the skull base, and I have them on WhatsApp. You have them on WhatsApp. We basically just chat every now and then. What do you think about this? What do you think about that? And it's definitely helpful to have those mentors on a worldwide level as well as a national level to take some opinions. And I think, yes, it definitely is beneficial. And they definitely can. We've had a few of them visit us as well to this place itself. And we haven't really done any live surgery or anything like that, at least in our center, but definitely I think it could help doing that. We do annual courses, as I showed, and it's a lot of fun. And we always have both disciplines. I didn't mention this. We always have neurosurgeons and rhinologists at the same time. This is divided half and half. So we always have a neurosurgeon and a rhinologist, or an ENT and a neurosurgeon on the same table. So they all have to work as a team. And it's beautiful to see when they actually learn from each other. The ENT guy teaches the neurosurgery guy the anatomy of the nose. The neurosurgery guy teaches the ENT guy the brain anatomy as well from an intracranial aspect as well as from an endoscopic aspect. So it's a beautiful thing to see when you just put people together. So yes, skull-based courses are an essential requirement, and you have to do them on a yearly basis.
Thank you. Last but not least, for our junior colleagues, is there any chance for anyone that would like to visiting you to see how you build your establishment, to get some more information and to be somehow trained by yourself by observing something like this?
Yeah, well, so we tried opening up for international fellows. Unfortunately, there's some logistic issues still, but hopefully they will open up. They just opened up for the Greater Gulf. We've had now two fellows from other countries within the Gulf region, but we're hoping for international openings as well. The center is always open for anyone who wants to observe at any point. Of course, it's an honor to have anyone observe anything at this point, and it would definitely be our pleasure to host anyone.
That's some good point that we should share with our colleague, because it's important to have international people around the world that should know if they're interested to get you. If anyone interested, I think that Professor Saad Alsaleh will be able to send an email by yourself. You can type your questions and then reach directly throughout him. Thank you, Saad, for being with us.
No, my pleasure.
I hope to see you again. For anyone interested, you can watch this panel again on our YouTube channel. It will be available in the next few hours. Just a quick reminder for the upcoming meeting, 26th of November. We have Serkan Gode from Turkey, which will talk about harvesting rib cartilage in primary and secondary rhinoplasty. This is a step-by-step, so you can make it for yourself. Thanks, anyone, for watching. Thanks, Saad, for being with us, and see you hopefully soon.